Hi, welcome to Pharmaceutical Care in HIV and welcome to Module 1 where we'll be talking about HIV transmission and a little bit about HIV biology. I'd like to remind you that this is an adult learning course, and by adult learning I will be doing very little conversation. If you notice, the slides are just about 12 slides in this Module 1, and I'll just be briefly picking on some issues regarding the topic of discussion, and then what I intend to do is provoke you to study a lot or research quite some on your own and then participate in the discussions that we have. I believe that when we discuss on these topics and when we are able to translate the topics to patient care issues, we are able to own our responses and own our ideas, and are able to articulate it better to people who may ask us questions regarding these topics. So here we'll be talking about the natural history of untreated HIV. We will discuss a little bit about the human immune response, and then we will learn how to provide answers to patients when they ask us about HIV transmission. And believe it or not, they come with so many questions. And also we are going to begin to talk about acute HIV infection and what that means to us as practitioners or as pharmacists. So let's start. The very first thing we're going to remind ourselves about a few facts about HIV that make it unique. The fact that it's a retrovirus. It has a half-life of 30 minutes, but its strength lies in its ability to replicate and replicate in large number. It is says that HIV produces about 10 billion virions per day. I don't think I know of anything in life that is produced at the rate of 10 billion per day. And with this large-scale production comes the error that comes with production. So HIV is error-prone. We call it error-prone, but I think that is a strategy for survival for the virus, because in this error, it's able to mutate and produce quasi-species that begin to evade the drugs that we use to treat HIV. The next thing we'll talk about are the different myths that are out there that I will need for you to be aware of and learn how to clarify with your patients. Believe me, there are so many more myths that I can mention, and sometimes when I talk to patients, I tend to think, where in the world did they get these ideas from? But suffice it to say that HIV does not come from swimming, and we all know it doesn't come from kissing, mosquito bites, and even human bites. The other thing that I also wanted to make strongly clear is that the fact that there are drugs available for HIV now does not eliminate the risk of transmission. It does reduce the risk, but does not completely eliminate the risk. And this is especially for some of our patients who have risky behavior because they are confident that their partners are on drugs and as such will not transmit the virus. Alright, so now that we have cleared the myths and how HIV is not transmitted, the next slide we're going to look at is how it is transmitted. And really, I think that based on my pretest with you all, that you have pretty much a good idea of how HIV is transmitted, but I wanted to bring your attention to the risk factors, or what are the risks of transmission, bearing in mind the different modes of transmission. And you can see that blood transfusion carries the highest rate, which is 90%, and you also have insertive penile vaginal intercourse carrying as low as 5 per 10,000, and little things like biting, spitting, throwing body fluids, and even sharing sex toys have negligible risk attached to them. I also attached have the list of articles that produce this data on the risk, and one would now begin to ask, why then, if the risk of acquiring HIV per act is as low as 5 per penile vaginal intercourse. Why then do we have so many HIV um, patients in our environment? Um, as I was preparing for this slide, my son came in and saw this particular slide and said, "I don't understand this question." And I said, "Yes, that's why I'm asking it. I don't understand it." So why then do we have, since we have low risk of transmission per act, um, do we now have so many HIV cases? And what should we tell our patients who come with this data? Because some of them may have this data, or this data may have been passed on to some people. And what should be our response to patients when they ask us this question? So think about it. How efficient then is HIV transmission in heterosexual couples? Do you think that heterosexual sex, which is what we have predominantly in our environment, never mind that we have a gay law right now, but do you think that heterosexual sex is an efficient way of HIV transmission? And so when I asked my son, so what do you think? Why do you think that, given the low probability that people still have it? And he said, because they do it all the time. And I think that's also a good reason, because they do it all the time. When you think about it per act, it may not necessarily be um, an efficient transmission method, but repetitive act. And the other thing to consider is the fact that in these studies that produce this data, didn't tell us at what stage in the HIV cycle this data was measured. There's a lot of recall bias. There's so many things that makes this data not enough to explain everything about HIV transmission in heterosexual sex. And so the other things too is, if you have a 1 in 200 chance of something happening. Let me for instance say, if you fly by air, you have a 1 in 200 chance of dying. I would think that a lot of people will opt out never to fly and choose to drive. Let us also, assuming that the risk of dying on road on the highway is not as high as 1 in 200, but people, once there's that little risk, the natural human being or the normal thinking person will not want to take the chance, because you may be that 1 in 200. There have been reported cases of people who have gotten the HIV infection in just the first sexual encounter. So the fact that the risk is low does not make it does not make it non-existent. And but we will be reading some more articles, and I would like you to think about it some more and come up with your own answers, with your own thoughts, and we'll share it as we go along. So so when the virus enters the body, the first thing it does will be, the first thing typically is exposure to mucosal surface, which is typically in our environment through sex. Then the first line of defense will be the dendritic cells, which will be innate immune response. And so the dendritic cells tend to capture this with their finger-like activity, and what they do is eat this virus up like they do other particles, and then they tend to take it to the lymph node. For the HIV virus, for most other foreign particles, this results in destruction. But because the HIV virus targets the CD4 cells in the lymph nodes, it compounds matters for the individual. And so the HIV now uses the CD4 cells to propagate itself, and then you have the virus spreading to other organs. And all these occur within the first 11 days, in 2 weeks of exposure. So you want just a brief recap. Your first response will be the dendritic cells and the macrophages, which is a innate immune response. But before then, you always also remember that the intact skin is the first barrier to HIV. HIV is unable to pass through an intact skin. And then the adaptive response, which will be our CD4 cells with the receptors on it, will be the active response. So the next thing we'd like to talk about will be what happens in an untreated HIV infection. This slide, I'm sure you're very familiar with, shows HIV RNA as a dark line, and the lighter line will be a CD4 cell. You notice that at the point of infection, you have a high CD4 with a low HIV RNA. Within the first 2 weeks, you have a peak in your HIV RNA and a dip in the CD4. And then begins the long battle of 7 to 10 years battle between the HIV RNA and the CD4 cells, till the CD4 finally gives up between the 7th and the 10th year, and that's when we start having opportunistic infections. Now, why do I bring up this graph? Because this graph tells us a lot about what happens in the body, or what the blood levels of HIV RNA in the body. And if you remember, one of the determinants of infectiousness will be the level of HIV RNA in the body. So if you look at this slide, within the 2 weeks of the first 2 weeks of HIV infection, you have a very high HIV RNA, and then because of that, you would expect a high risk of transmission at that stage. The next time that you have such a high risk, which is about a 2 to 3 year period, will be in opportunistic infections. Now, this chart also comes into play because a lot of people in that first 2 weeks do not know that they have HIV. In fact, HIV tests will not detect HIV antibodies at that stage. Most facilities, and if not all facilities in developing countries, do not have the means to detect HIV RNA. They will detect antibodies but not RNA, and as such, you find a lot of people who are clueless about their status, who are very generous with the virus at this stage. And so, as pharmacists, I think we should begin to think about this issues that come up, because with HIV, prevention is the best way to cure it. So acute HIV infection, the first 2-3 weeks, in fact, it lasts up to 6 months for a lot of people, where you have the body following the initial HIV infection, and you have initial burst of viremia, and like I mentioned earlier, you have undetectable antibodies, and for a lot of people, it is called HIV infection, early HIV infection, or primary HIV infection. But I think it's a critical period in HIV care. In this period, you find out that patients may be asymptomatic, but you have symptoms that occur between 40 to 90% of patients, and these symptoms are non-specific, and so patients will go to the doctor, and maybe they're diagnosed with things like malaria, just your stress, go and rest, but it may be a HIV infection, and which is why it is important to take a good sexual history before things are done. But you know that at this stage that there's a high viral load, a high risk of transmission. The question has always been, and the debate has always been, do we treat at this stage or do we not treat? And that's one question that I will bring up as we go on to do our discussion and read articles and read and hear what the research has said, and see whether, even if it's not practicing in the country, is this something we should move for? Is this something we should consider? Do we treat patients? Do we begin to diagnose patients in HIV patients in acute infection, or do we just wait to use the antibodies? And even if we can't treat an acute HIV infection, are there steps you can take to prevent? Because I believe that this period is very critical. Those 2 to 4 weeks where you have that high peak viremia. In fact, it is said that about 20% of HIV infection occurs in that period. So if we are able to target that period, I think that we'll be able to reduce a lot of our transmission. So let's think about it. So I have two articles that listed below here. One of them is discussing the brief but efficient HIV transmission in that early acute phase, and the other one discusses models of interventions to increase diagnosis or even reduce transmission in that acute phase. And I'd like us to think about it, talk about it, and see what we can, what we can come up with regarding this situation. Now, thank you so much for your time. And if you look at the website, you would see the discussions and the assignment that are given. Feel free to send me an email if you don't understand what I want you to do. Feel free also to communicate to me. As far as the discussion goes, it's really very important that you post your initial discussion or thoughts early on, so that we're able to build a discussion over the 3 weeks that this particular module lasts. I would rather have the first your initial post in the first week of the module, and then subsequent posts will come up. Please refrain from making your input in the last day of the course. It doesn't benefit anybody. This is a discussion that we will learn from. So if you post it on the last day, nobody would have read it, nobody would have thought about it, and it's unfair to your co-participants. Thank you so much for your time, and I wish you all the best in this endeavor. Thank you.